So when it comes to imaging the spine, sort of these different imaging techniques sort of have different roles. And radiographs, I mean, there used to be these rules about like when to do C-spine radiographs from the ER, and they're totally pointless because radiographs are useless in that setting. Radiographs are useless in almost every setting when it comes to evaluating the spine. That's why when you come to neuro, you hear us like complaining like so greatly about like who's assigned to Scully radiographs because they're just terrible. And it's just like a setup. Like basically the only thing that can happen is you can like miss like a horrible tumor and like basically provide no value. They are kind of useful for dynamics. So you can do like C-spine films and flexion and extension and kind of see if there's dynamic, malalignment or something like that. You guys know, you go to county, CT is like your screening test of choice. You do it for alignment, you do it for trauma, you do it for hardware. But the real workhorse of spine imaging is MR because you see the soft tissue anatomy so well. You see the spinal canal. Myelograms are sort of like going the way of pneumoencephalography. There's like some old school like ortho surgeons who like really want them before they take people to the OR. But the reality is like anyone who has like a high quality MR does not need a myelogram. The reality of it then becomes when the orthosurgeon wants it, you still do it because radiology is a service oriented profession and you sort of do what it takes to make them happy. The real indications for myelograms are when someone can't get an MR, or so if someone has a pacemaker and is pacemaker dependent, they can't get it because they have metal in their eye or whatever, then a myelogram is good for looking at that disc anatomy and you can evaluate the spinal canal. But more often than not, the patients have high quality MRs and the surgeon's like, well, I just want it. And you're like, well, why? I want to see if the disc is calcified. Well, okay, that's actually a valid indication, but you don't actually have to do a myelogram to do that. You can just do a non-contrast CT. And they're like, no, just do the myelogram, please. And so we do it. The role of contrast in the spine has always been like a little confusing because most of the time you really don't need contrast that much. When you're evaluating trauma or degenerative disease, you almost certainly don't need contrast. These rules kind of apply to both CT and MR. If you're doing CT, you almost never need contrast because you're expecting that if there's something bad, you're probably going to get an MR anyway. The times that you might do it is if you, like I said, you know the person is not going to be able to get an MR and you're looking for abscess or some complication of surgery or something like that. For hardware, like many times they just want to see where it is. If it's malpositioned, if it's broken, if it's loose, then you don't need contrast. Now, in patients that have had surgery, like contrast becomes like a little bit more controversial. In the immediate postoperative setting, patients should get contrast on their MRs because you have a risk of abscess. You have sometimes granulation tissue and things where it can be hard to differentiate like a disc from scar, and that sort of becomes useful. If someone has had surgery like say more than 6 months ago, then it becomes like a little controversial. I think like probably either one is okay. You're going to find like people who like feel one way or another. If someone has like very remote surgery and has been fine and you're just trying to see how the degenerative disease is going, I would say no. If it seems like someone may have like an ongoing complication of surgery or recurrence of a disc or something like that, then I would say give them contrast. Those other indications, demyelinating disease, tumor, infection, METs, give contrast. If someone can't get contrast because they have a contrast allergy, because their GFR is 6 or whatever, the majority of the information you get from a non-contrast MR. There are a few things that are, it's markedly better to do the contrast study, but the non-contrast MR is still, it's superior to a contrast CT. You get 90% of the information. You may have to speculate like about, is this like a MET or, something else, but you're going to see, and many times you can like clear a normal spine. I'll make a comment about numbering. I didn't really know this until I started being a fellow. There's a lot of variation in like the number of vertebral bodies, and the only real, truly reliable way to number them is from the top. Is to start at the dens, call it C2, and go down. A lot of times people have 11 ribs, 13 ribs, 6 lumbar vertebral bodies. It can be very confusing. one way that you can get sued as a radiologist is if you call a disc or a tumor at the wrong level and the surgeon does it at the wrong level, like does a wrong level surgery, you're going to be there in the defendant's box with the orthopedic surgeon. Many times, and we don't often start at the head. I mean, sometimes they do these numbering sequences and you see them at the top, but you don't always have that. So you use other things to number them. Like sometimes you'll label the last rib T12, you'll label the last real disc L5S1. That's actually fine. If you are consistent about it and you say that you did that, then you're pretty much perfectly protected. Even if you were wrong, if there were 6 lumbar type vertebral bodies and you labeled the last disc as L5S1, that's okay, as long as you said in this report, I labeled it L5S1. I don't know because I can't see the ribs, but I'm calling it L5S1. That draws the neurosurgeon or orthopedist's attention to it, and they have to look at the images themselves to decide what level it's at. So I would encourage you guys to do that. And I think like the templates, like for lumbar spine, for instance, like even have that in there. And I would encourage you guys to at least pay attention to that, even if you're not saying it in your reports. The general approach to like looking at spine imaging. So when you're looking at brains, you come by, you're at Moffitt, like it's your first CT rotation. You sort of use the axials, and then the recons, like, I don't know, maybe we like blow through them quickly, or we use them for troubleshooting. Spine is like exactly the opposite. In the era of helical CT that can be easily reconstructed, you want to use them first. They're much easier to understand, and they're much more information dense, and you can understand it much better. I'll show you an example. So this image, like this is from a trauma CT. You're kind of looking at it, and you're like, well, like, is this normal? Like, is this abnormal? It doesn't seem like quite right. I'll show you like the associated like sagittal image. If you have to choose which one you're trying to decide, like what's wrong here, you want this one. Like here, it's obvious, like there's a big subluxation. The facets are going to be perched, but here you're like, well, I don't know. I mean, like, yeah, this like. But you're looking, you're like, well, I don't know. Is that a facet? Is this two things that are like perched on each other? Like, I don't know. It's very difficult to tell. Here, it's like super obvious. You sort of know what's going on, and then you know what to look for. So definitely like use those, and then follow that up with the axials. And then reality, like the localizer lines, like become much more important because you can use the sagittals particularly to know what level you're at and find out kind of what's going on. And then don't forget about the soft tissues. It's very important, like to not miss a thyroid tumor, a renal tumor. If you're doing like a MR of the L spine for degenerative disease and someone has renal cell carcinoma, that's another way to like end up in the defendant's box. Another comment, sort of non-contrast is your friend. Like on brain, we sort of like just go through and we're like, yeah, non-contrast. We look at it if there's something enhancing to see if it's like intrinsically bright, but we don't pay that much attention to it. On spine, it's like one of the most useful sequences that we have, because one of the best signs of like a bony process, like a metastasis, is losing that normal fat. In some ways, it's even better than post-contrast, because many times like the post-contrast will enhance exactly to the degree of the fat, and then you end up with a lesion that looks exactly like the adjacent fat. T1 is also the best for looking at the neural foramen, because you have that fat, and it's like that loss of fat that characterizes what the neural foramen is like. Another little interlude for you guys. This guy like had rib pain after he hugged his girlfriend. Girlfriend is very powerful, apparently. So now we'll talk